Okay, welcome everybody. And here we are. We only have 2 more weeks left. Tonight, we're going to be doing hopefully 2 chapters, chapters 20 and 21. 20 is nutrition and diabetes mellitus. And that's where we are going to start. So I'm going to make our faces disappear, put us up here, and let's get through this chapter. So what are the learning objectives? We're going to talk about the 2 different types of diabetes, type 1 and type 2. Type 1 used to be called juvenile diabetes. And we're going to explain how diabetes can be managed with dietary adjustments and medications and so on and so forth. I'm actually going to pause the recording for 1 moment. All right, back to recording. Let's share the screen, chapter 20, and there we go. All right, we're going to talk about how diabetes can be managed with diet. That's the first line of defense, then medications and physical activity. The effects of diabetes on pregnancy outcomes and how we manage glycemic control in pregnant women with diabetes. We're going to talk about the features and consequences of what's called metabolic syndrome and what the treatment approaches are for that condition. So what is diabetes mellitus? So it's a disorder, it's a metabolic disorder. And what happens is the foods that you eat, any of them that have sugar, the sugar is elevated in your bloodstream and cannot be distributed to your cells for your cells to make energy, right? And so it's one of 2 reasons. Either your pancreas is not making enough insulin or no insulin, or your cells get resistant to the insulin. So they're not able to let the insulin bring the sugar out of the blood and deliver it to them for food. So that what happens is all that sugar is stuck in your bloodstream, and that is called hyperglycemia, or too much sugar, elevated sugar in the blood. There are some real classic telltale symptoms of diabetes. These symptoms are usually for type 2, because let me just say, I know it's not in the slide, but type 1, which used to be called juvenile diabetes, that is a sudden onset. So usually happens to children, teenagers, and young adults. It's an autoimmune disorder and it's genetic. If you're going to get it, you're going to get it. It's congenital. So in other words, you're fine. And then the next thing you know, you're not fine. Boom, you pass out, you go to the ER, and they find your blood sugar is like 1,000, which is very high. And normal fasting blood sugar, by the way, is 60 to 100. So you don't really get these signs. But with type 2 diabetes, which is the most prevalent in this country, that has a real slow and insidious onset. So what happens is people actually bring this on themselves by leading sedentary lifestyles, eating too much sugar, too many foods high in the bad sugar, white processed sugar, no exercise, like I said. And if it runs in your family, you really need to be cognizant of it and hope that you don't get it. And type 2 diabetes is reversible, which is the nice thing. Type 1, no, right? So with type 2 diabetes, you have the 3 Ps, we call them. Polyuria, which means you pee and pee and pee all the time. Polydipsia, which means you're thirsty all the time. And polyphagia, you're hungry all the time. They're the 3 Ps, classic sign. You also you feel dehydrated. Your mouth is dry. Initially, you may lose a little bit of weight. It's sometimes. Visual deficits like blurred vision, double vision. The increased infections don't really occur until later on. Okay, so I don't know about that being an early sign. And fatigue, you feel just so tired. And how do we diagnose it? Well, a couple ways. The first way is basically checking your blood to see how much sugar is in it. And that's just a basic blood sugar test, right? There's also something called a glucose tolerance test. For women in the class that were pregnant and have had kids, they often use that test for gestational diabetes, which is a different diabetes. It's only when you're pregnant. They give you, you go in fasting and they check your fasting blood sugar, and then they give you this drink that is just, bleh. It's nothing but sugar. And then you wait 2 hours and they check your blood sugar to see if your body was able to process that drink. And anything greater than 200 at the end of that 2-hour period is diabetes. 140 to 200 is borderline. You should be 140 or lower for it to be normal, okay? And there are other tests like a hemoglobin A1C that we can do as well. So a random blood sugar of greater than 200, a fasting blood sugar of 126, no, 120, 120, and plasma glucose concentration greater than 200, 2 hours after you drink that nasty drink, that 75-gram glucose load drink. When we talk about diabetes mellitus type 2, people can be pre-diabetic, which means that the blood sugar levels can kind of fluctuate between being normal and then being a little on the high side. So for people that are pre-diabetic, you'll see their fasting blood sugars greater than 100, but less than around 125. And like I said, with that glucose tolerance test, 140 to 199 is considered pre-diabetes. If you are pre-diabetic, you are at a very high risk of developing diabetes, and cardiovascular disease goes hand in hand with diabetes. So does kidney disease, and so does peripheral neuropathy, and so does diabetic retinopathy. And I could go on and on, okay? So you don't want any of that. So here we go, type 1, it's autoimmune. There are 3 types of cells in your pancreas. Beta cells are the ones that make insulin. Alpha cells make glucagon. So there's a destruction of the beta cells by your own immune system. Your white blood cells attack them. So your insulin can't be made, which means I have to give you insulin by injection. Environmental toxins or infections, no, that's not based in science. The Merck manual would disagree. But it does develop during childhood or adolescence or young adult. And the symptoms always appear abruptly. They don't ever appear gradually. Ever, ever, ever. They are abrupt. It's like a ton of bricks hitting you. Okay. And so here we go. I'm sure I'm going to have to change some things in this. The prevalence in diabetic population of type 1, very low, 5 to 10%. That's about right. Type 2 diabetes, 90 to 95% of people with diabetes have type 2. In other words, it's preventable. They didn't have to get it. And I'll tell you this fun fact. Children now, ages 10, 11, 12, are being diagnosed with type 2 diabetes, which never happened, ever, ever, because they are leading sedentary lifestyles and they're overweight. For type 1 diabetes, it's usually younger than 30. You know, it's going to come on. Type 2 used to be greater than 40, but not so much anymore. Conditions associated with type 1 autoimmune diseases are really the big thing, and congenital, it's inherited. Type 2, obesity, aging, inactivity, and it does run in families, but you don't have to get it, right? You can do things to prevent yourself from getting it. And what's going wrong? Well, the major defect with type 1 is the pancreatic cells are getting destroyed, so you don't have enough or any insulin. With type 2, there's an insulin resistance and an insulin deficiency. Basically, your pancreas just taps out. It's like you're eating too much sugar. I can't keep up, right? With type 1 diabetes, you're not making any insulin or very little. With type 2, it depends. It can be a normal production of insulin, but the cells are resistant, or it can be a decreased production of insulin. All type 1 diabetics will be on injections of insulin their entire life, period. With type 2 diabetes, we can start out with modifying diet and lifestyle. We can then use oral medications. There's, metformin, glipizide, lots of oral medications. And sometimes we can reverse it, but sometimes even the orals don't work and we have to put type 2 diabetics on insulin. And they used to call it juvenile onset diabetes, type 1, or insulin dependent, IDDM. Now we just call it type 1 and type 2. Type 2 used to be called adult onset or non-insulin dependent, but that's not really true because now kids are getting it and some people are on insulin, right? So things change. We have to change along with them. Most cases diagnosed in adults over 40 or 45. I would say that it's not rare in children anymore. So it is increasing in prevalence in children. Overweight children and those that have a family history are usually at a higher risk. And it's sometimes not detected in children. right? Unless they're really screened for it. Type 1 and type 2, difficult to distinguish. That's not even close to true or fact. I'm going to pull the Merck manual up to address some of these things. Acute complications. So here's the problem with either type 1 or type 2. Every time your blood sugars are elevated and all that sugar is stuck in your bloodstream, it cannot get to your cells, so your cells are starving. They have nothing to eat. Diabetic ketoacidosis. You've heard the keto diet. Basically, what's happening is that your cells are starving because they don't have insulin, and they have to burn something to make energy. So they will start to burn fat, sometimes even protein. And the burning of fat and protein can actually produce something called ketone bodies or ketones. And ketones are acidic and they spill into the bloodstream. And what happens is your blood pH starts to drop. The ketones are also in your urine and your breath, which makes your breath smell a little fruity, believe it or not. Can you mute, please? Thank you. Your urine and your breath will smell like juicy fruit gum, believe it or not. So even though they're acidic, they have this like a sweet and sour kind of a smell to them. And you will die because the pH of your blood, as it drops, it can't support the transport of hemoglobin, which means all your organs aren't getting any oxygen. You will slip into a coma and you will die without IV insulin right away. Blood glucose levels, they're saying greater than 250. I've had people come in acidosis with levels greater than 1,000. And so I used to say hot and dry, sugar's high, cold and clammy, give them candy. So symptoms of these high blood sugars with ketoacidosis: dehydration, they're very dry. The breath smells acetone or like juicy fruit gum. Blood pressure will start to drop. They'll be confused, fatigue, lethargy, nausea, vomiting. Like I said, they'll slip into a coma if there's not intervention. With type 2 diabetes, what they wind up getting when the sugars are elevated for a period of time is hyperosmolar hyperglycemic syndrome, okay? And that's basically the same thing, except here, severe hyperglycemia and dehydration, but this is a slow, insidious kind of torture. Blood glucose levels, excess of 500, 600, 700. They start to have these neurological problems, like getting confused or even combative or agitated. And they don't even know that they're thirsty, so they don't drink. And they wind up, same thing, ultimately in a coma, right? So either way, very dangerous. Now, on the other side is hypoglycemia, which means there's not enough blood sugar. It could be for a lot of reasons. Not the right amount of insulin or oral drugs. They exercise too much. Skipping meals, can't do that. Not eating enough. Drinking alcohol without food. And, they occurs most often in type 1. That's not true. Hypoglycemia occurs in both type 1 and type 2, depending on the way that person is managing their diabetes. That's really what it boils down to. So when you're hypoglycemic, remember, cold and clammy, give them candy, right? So you're going to feel hungry, sweaty, shaky, weak, dizzy. You may even get heart palpitations. And then as it progresses, if there's not an intervention, you will start to have these neurological issues, like your speech will be slurred and you'll get confused. And again, you can slip into a coma and die, okay? So macrovascular complications, and I'll talk about microvascular complications. We'll do it together. Vascular means your blood vessels. So you can have diabetes, type 1 or type 2, your whole life and never have a complication as long as you manage your diet properly and you don't have episodes of elevated blood sugars. When you have these episodes of elevated blood sugars, all that sugar in your blood is eating away at the blood vessels and the nerves of the kidneys, the eyes, and the lower legs and feet, okay? And so one of the first places is the feet. This is a diabetic foot ulcer. They're a very common complication of uncontrolled diabetes. Circulation is impaired, and people will actually have burning pain initially, and then they will lose all feeling in their feet. So I had people step on things like nails and tacks and never even knew that they did that until somebody came to visit and went, what's that smell? Well, it was grandmom's foot because it was gangrenous, right? And then that's how amputations start. So foot ulcers are a big problem with uncontrolled diabetes. And then we have the neuropathy and the retinopathy. So in other words, eventually these uncontrolled blood sugars will cause blindness and will also cause permanent damage to the kidney to the point where the patient will need to be on dialysis because their kidneys will be done. Okay. Diabetes is chronic, it's progressive, but type 2 can be reversed. So it's not progressive. So I don't like the way this is written either. Type 1, there's nothing we can do. You will be on insulin the rest of your life. And the biggest thing for both type 1 and type 2 is what you're eating, when you're eating, when you're taking your meds, and how much you're exercising. It's like a balancing act, right? But if you do it well, you can never have a complication. So the biggest goal is to keep that blood glucose within range, right? And that requires really, watching diet intake. When we talk about blood glucose monitoring, this is a little table that talks about conventional therapies versus intensive therapies. When people are having difficulty monitoring or controlling their diet and their blood sugars are way out of control, we're going to be checking their blood sugars usually 4 times a day, before breakfast, before lunch, before dinner, before bed, right? Which is cumbersome to be sticking your finger 4 times a day, 7 days a week, 52 weeks a year, Insulin can be given as injections when it's conventional. Sometimes they can be on a long-acting insulin, which is given once a day at bedtime. But for these people that are having difficulty managing it, they will be on 3 or more injections, or maybe they'll be having an insulin pump, right? And their dosages are going to be constantly changed and tweaked, right? To try to get them where we want them to be. The advantages, again, you're not going to have problems as far as hypoglycemic episodes and those kinds of things with the conventional therapy. And if you monitor and keep your blood sugars well controlled, if you don't, then you're going to have all those other problems like the diabetic retinopathy, the eyes, blindness, nephropathy, the kidney damage, and neuropathy, the damage to the feet and the legs. So it really is an ugly disease. 95% of the patients that are on dialysis, and I don't know if you know about dialysis, but that is 3 days a week for the rest of your life. And usually anywhere between 4 and 6 or 7 hours a day. So you go Monday, Wednesday, Friday to dialysis. Tuesday, Thursday, Saturday, you sleep all day because you're exhausted. You have 1 day, Sunday, and then it's back to dialysis. That's your life. And it's not fun. To evaluate the treatment to see if it's working, one of the big things we do is the hemoglobin A1C. That's glycosylated hemoglobin, not glycolate. Okay. Glycosylated hemoglobin. And what that means is over the past 3 months, how much sugar is stuck on your hemoglobin, on your red blood cells. So we're not checking your sugar level. We're looking at your hemoglobin, your red blood cells, to see how much sugar has been stuck on them. And it gives us kind of a peek into the last 90 days of what your blood sugars have been. And just FYI, for people that are diabetic, we want that hemoglobin A1C to be below 7%. For non-diabetics, it should be between 4 and 6%. If it's lower than 4%, you're dead. Monitoring these patients for long-term complications, right? We're going to check their blood pressure, their lipids, cholesterol, et cetera. Checking their urine for protein, because that tells us if there's kidney damage. Because when the kidneys are damaged, instead of hanging on to protein, they excrete protein in the urine, and that's a telltale sign. Ketone testing, we can dipstick urine to see if there are ketones there. And with people that are diabetic, any incidence of stress, and stress can be physical stress like illness, psychological or emotional stress, and pregnancy is stressful. So all of those things increase the risk of blood sugars going wild, okay? So people that are diabetic have to be even more cognizant of their blood sugars if they're sick, if they're stressed out, or if they're pregnant. And so nutritionally, there are lots of different things that we can do to slow the progression of the complications, right? Like looking at the carbs, because carbs are sugars, but there are good carbs and there are bad carbs, okay? So if it's white, it ain't right, okay? The things that are white, like white sugar, white flour, white rice, white pasta, those are simple carbohydrates. And what that means is simple carbs, when you eat them, they go in quick, they raise your blood sugar really crazy quick, and then they get out of you quick. What you want is you want slow and steady because that wins the race. So you want the brown things, the long acting carbs, which are your whole grains, things like, don't eat white bread, eat wheat bread or whole grain bread, or rye, legumes, beans, fruits, vegetables. All of those things have carbs and they're better sources than the white refined sugars. I will add this, fruits have sugar in them. Some fruits have a lot of sugar in them. That's why they're sweet. And when your body breaks down the actual sugars that are coming from fruits, fructose, it breaks down into a simple sugar. So really, whole grains, legumes, and vegetables, fruits, be careful with because they can make your blood sugars go bonkers. When we talk about something called the glycemic index, that's kind of a thing that we use to rate different kinds of foods based on how quickly and how much they raise your blood sugar, okay? And foods like the obvious things, ice cream, cookies, cakes, candies, right? Those are simple sugars, white bread, white rice, Sometimes there are hidden sugars in things like sugar alcohols, which are not good. Artificial sweeteners are okay for diabetics, things like, Equal or Splenda. But sugar alcohols, sometimes people don't realize that your body will break them down as a simple sugar as well. So you've got to really, really, really learn to read labels. You should be getting the, fiber just like everybody else. Dietary fat, monounsaturated fats. Everybody needs a little fat, right? But the good ones, not the bad ones. Protein guidelines are the same. Really, the big thing is the sugars, the carbs. It says here, use alcohol in moderation. I would say, I would stay away from alcohol because it's just sugar. It's just sugar, all alcohol. I don't care if it's beer or wine or hard liquor. It's just sugar. Micronutrients like vitamin and mineral supplements, again, you don't need them, just eat. And especially with diabetics, a lot of them, these supplements are based in sugars. And so that's the last thing that you want to be giving somebody who's diabetic, right? So small, frequent meals. I can't say that enough. It's the key to life. Meal planning strategies, portion sizes, right? You don't want to eat enough to choke a horse. It's not good. Carb counting, which, you can do, or you can, there are lots of different approaches to this. Carb counting is one, the glycemic index is one. But, when we look at something like this, for somebody who's taking in 2,000 calories a day, they should have 60 grams of protein, which is about 4 portions of a carb, right? At breakfast, at lunch. They should have a snack, dinner, and then another snack. So do you see how it's 1, 2, 3, 4, 5? It really should be 6. Basically smaller meals in a day. So this way you're not having these roller coaster up and down, up and down. Blood sugar, you want it to be nice and steady and stable. Okay. Here's a pretty little sample menu. That's, some things that people can eat. Milk, milk has a lot of sugar in it. Juices, like fruit juices, a lot of sugar. So if they're going to be using milk, they should be using low fat or skim milk, right? It's got less sugar in it. Again, brown things, not white things, maybe peanut butter on wheat crackers or wheat toast. Great, And then I'm not going to get into all the insulins, but there are quite a few. So, when I teach nursing, I go into the Glargine and the Levemir and Lispro and regular insulin and NPH. I think there's a little table here. Yep, there you go. So basically, I don't believe that you guys need to know the insulin preps, but depending on what kind of insulin a patient is on, they have to be cognizant of when it peaks, especially because if they're on like Lispro, they better eat something in 15 minutes or they're going to bottom out, right? If they're on regular insulin, they better eat something within the hour or they're going to start to bottom out. And NPH, which is a very commonly used one back in the day, not so much anymore. NPH is intermediate, so it'll last somewhere around 10, 12, 15, 16 hours. It says here 10 to 18. Your long-acting insulins, which Glargine and Detamir are the two big ones, right? Lantus and Levemir, they don't have an onset of action. So I don't know where that came from. And they don't have a peak. They just basically, they're like basal insulins. They're slow and steady. They're given once a day, usually at bedtime. And they, the hope is that it keeps the blood sugar stable for a 24-hour period. And, understanding what they're on so they understand when they should eat, what they should eat, when they should exercise. All those things are so important. For type 1, most type 1 diabetics now are using insulin pumps, which are fabulous. They really make it a little bit easier because it's very cumbersome. Where, back in the day, people would have to self-administer insulin. Here with a pump, the pump is loaded with insulin and it does a couple of things. It's got a little tiny needle in a patch type thing that attaches somewhere onto the abdomen because that's subcutaneous fat. And it's able to check your blood sugar and administer the insulin. So this way you don't have to do much of anything except hopefully take better care of yourself. It says here 30% of type 2 diabetics benefit from insulin. The goal is to reverse the type 2 diabetics, like with what they eat, physical activity. If it gets worse, then they may need insulin to keep control. And some people genetically it's very difficult for them to control also. And again, they can be on different types of insulins in combination with oral medications, lots of different types of regimens, There are some things called the dawn phenomenon and rebound hyperglycemia, which kind of are the same thing. Basically what happens is if that patients with diabetes don't eat a nighttime snack, they must eat a nice long-acting carb and maybe a little protein before they go to bed. Because what can happen is during the night, their blood sugar will drop. But then closer to morning, the pancreas will go, what's going on? And all of a sudden we'll release like a bolus of insulin, I suspect with type 2 diabetics, and they'll wake up with hyperglycemia. So you never knew that they were actually low blood sugar at like 2 or 3 a.m. because they wake up with a blood sugar of 300, and then the doctor will increase their insulin and their blood sugars will keep going up instead of down, which is crazy, but it happens. It's actually happening more now than before because people aren't managing diets right. Pills, lots of different medications. The only medication that is a different med orally than all the others is metformin. Metformin works on hepatic gluconeogenesis. In other words, stops your liver from converting glycogen to glucagon and putting it back into your bloodstream. It doesn't affect your pancreas. It doesn't make your pancreas make more insulin. It doesn't typically lower your blood sugars where you'll become hypoglycemic. And metformin's usually the first drug that they'll put people on. And then you see there's this whole list of other different types of drugs that are used. And most of them increase either insulin secretion or delay absorption of carbs or help the cells be not resistant to the insulin and the sugars. So they work on different mechanisms, but metformin is the only one that specifically works in the liver. Physical activity, people have got to move. I say this all the time. And if you're not a diabetic, start moving now because that helps prevent the insulin resistance in the cells so that you won't wind up diabetic later on, right? Remember, before you start an exercise program, you should always consult your physician and make sure you stay hydrated, Always check blood sugar levels before and after activity if you are diabetic, because that is when people actually are most likely to bottom out. And people that are diabetic should always carry with them some type of a short-acting sugar. There are even glucose tablets that you can buy at CVS or Walgreens or whatever and carry them with you. So if you start to feel the sugar going down, you can check it and you can pop a couple of those to get your sugar back up. Sick day management, like I said, when people get ill, it actually increases the risk of their blood sugars going bonkers. They usually will need more drug, or if they're not on insulin and they're hospitalized, say with pneumonia, we may put them on insulin just for the course of the hospitalization because we can anticipate the blood sugars going nuts. When people are pregnant, pregnancy increases that insulin resistance and the body's need for insulin. And it actually, there's a lot of risks. Now we're talking about someone who is diabetic when they get pregnant. Gestational diabetes occurs, so the mom wasn't diabetic and then develops it while she's pregnant. So they're two different kinds. Either way, one of the biggest risks is a macrosomic baby. In other words, a very large baby. But believe it or not, that very large baby is born with very low blood sugar and can be in a lot of trouble when it's born, as well as metabolic problems and respiratory issues with the baby. So you got to make sure that the blood sugars are controlled, make sure that mom is getting the right care. Again, talk about glycemic control. People that are already diabetic, women that are already diabetic should, if they know that they're going to be planning to become pregnant, really need to have a tight control of their blood sugars before they get pregnant, if it's at all possible. And type 1 diabetics usually need a lot of insulin when they're pregnant, and their dosage are usually just changed a lot. Gestational diabetes, like I said, there are some risk factors like family history, obesity, and if you've had big babies, and when I say big, it's bigger than 9 pounds. Most women are getting, the glucose tolerance test somewhere around 24 weeks, give or take. And again, small frequent meals, right? And limit carbs, the bad carbs, so that this way you decrease your risk of developing it. Metabolic syndrome is this cluster of symptoms that increases the risk of cardiovascular disease and type 2 diabetes. When you have 3 or more of these things, hyperglycemia, obesity, blood triglycerides and cholesterol elevated, bad cholesterol, good cholesterol too low, and high blood pressure. And it says here 23 to 34% of adults in the US meet that criteria. I would venture to guess that that number is much higher. I'd have to look that one up. So all these illnesses together, they're considered a syndrome, and each of them is a risk factor for cardiovascular disease, but together, that is really a higher risk, and it brings with it, even the risk of death. It's very dangerous. We really don't know precisely why it happens, but there have been study after study that have been done trying to find a causal relationship between body type, so people that have abdominal fat, right, particularly abdominal obesity, and that usually brings with it insulin resistance, right? And we believe that there is a relationship there between that and metabolic syndrome, right? Which is, there's probably some truth to it. They've been studying that for many years. What can we do about it? Again, you got to eat right and move, eat right and move. Diet and lifestyle changes. Got to lose some weight, increase your physical activity, get away from the bad sugars, the processed sugars, increase the whole grains, the fibers, those kinds of things, get away from the bad fats and the cholesterols, and get with the good monounsaturated fats. And, that's, like I say, what you are is what you have eaten and what you do. So can't say that enough. And that is the end of this chapter. So I'm going to say, peace out. It's getting dark.